Welcome to the lecture on hypertensive disorders during pregnancy. We are going to go through these objectives today, and we're also going to use this bag to help us prepare for what equipment we need when dealing with a hypertensive disorder. So, is there anything in this classification system that's new to you? These are the main things that come up when we talk about hypertensive disorders.
I know that they've been changing them throughout the years. Like there used to be like with severe features and without, so yes. I know that's changed.
Great. Are you familiar with the level for high blood pressure?
Yes,
what would that be?
160 for systolic and 110 for diastolic.
Okay, so that's our severe range. And what are we looking at for the high range below that?
140 for systolic and 90 for diastolic.
Excellent. So these numbers are important for diagnosing, and what would be the numbers for proteinuria?
Anything that has a number.
Right, anything above 0, or also if we're dealing with 24-hour urine, we're looking at a count of 300 or above. All right, great. So moving forward from there, we can see the pathophysiology of how preeclampsia develops. Any questions about this pathway?
No.
So one thing to point out is that it affects the whole body. And so all of the different systems are being affected, and that brings us to a point where we can't really figure out why preeclampsia is starting. So it's a myth that delivery is going to discontinue preeclampsia. That's not the cure. You can even get preeclampsia postpartum because it's really an interplay of all these different things. Okay. So our definition here, preeclampsia. Are you familiar with eclampsia?
Yes, that is the seizure.
Correct, yeah, so the progression, hopefully not, but possible progression. And let's talk about the severe features that show up with preeclampsia. That's part of the diagnosis. What do you see in the multi-organ system dysfunction cardiovascularly?
Usually they have some edema. And then I know like if you go into like their labs and things like that, you'll have a couple of differences in their lab aspects for cardiovascular.
True. And cardiovascular, we're also seeing
blood
pressure changes. Pulmonary, what changes do you see?
So they could be breathing rapidly because they have a lot of fluid on their lungs,
Yes.
or their oxygen saturations may be lower.
Yep, because of all that fluid. Excellent. How about renal changes?
So they might not be producing enough urine because of that cardiac output might not be getting there.
Right, and so we're going to see maybe protein in their urine. We also might see some lab values that would be different, and that comes into play with our hepatic as well. So our liver and our kidney functions are going to be impacted. What are you going to see in terms of hematologic changes?
Other than their lab values?
Well, a particular lab value, I'm thinking of platelets.
Oh, platelets, lower platelets.
Right, exactly. And then neurologic changes, what are you going to see?
Some of the normal symptoms could be headache, blurry vision, heartburn symptoms, but it could also just be a whole systemic different kind of system too. So.
Absolutely. So we sort of do our head to toe from memory. We ask about headache, vision changes, shortness of breath. We can talk about right upper quadrant pain, which would be related to the liver. We're going to talk about edema anywhere, and then ask about any other changes, because there could be other factors that fall into this. So here's our case study. Take a look. Our patient here has some risk factors. If she walked into our triage room, we would be thinking about her and be concerned for preeclampsia or other hypertensive disorders. So what things do you see in her case that would make you be curious or guard against hypertensive disorders?
She's a 40-year-old, so she's at risk for AMA.
Yep.
First-time mama.
Yes.
African American.
Perfect.
And also her blood pressure from the office as well. And then gestational diabetes could be a concern.
Could be.
But it might not play into it. But again, we'll see. And
not so much surgical history there.
Not so much, no. And late prenatal care.
Yes, late to prenatal care. And one more in her social factors.
Let's see, quit smoking.
Yeah. So she did, but she had been smoking during her pregnancy. So any history of smoking at any time is going to increase your risk. All right, so excellent job with that. So we're going to be concerned about her. We're going to ask her our symptoms, and we're going to run a PIH order set. So in our assessment, you already identified a lot of these things because we're thinking about the systemic changes and we're thinking about the pathophysiology. So we're asking the questions, as you said, serial blood pressures, because we need more than one.
Yes.
And I like how you already stated the oxygen saturation and understanding why. So moving forward, now the doctor has come in our case study. Now we've done our repeat blood pressure, it's a little high, and as you read through this, you see some of those severe features pop up. What are some severe features of preeclampsia that you see?
Her blood pressure is elevated. She has an 8 out of 10 headache. Let me see here. She has, let's see, +2 edema, and then...
So, +2 edema is...
Or +1, I should say, sorry, +1 edema. But that could be pregnant in most pregnant women. Exactly.
So in and of itself is not a problem, but when you see it put together in this, then you start to wonder, and that's why we're going to send our labs. Her reflexes are fine, her lungs are fine, so we're going to put this whole piece together and present it to the doctor. But we're thinking in the meantime about what's going on. So we're going to use this bag to figure out what emergency equipment we need to bring to the room.
Okay.
First off, let's imagine I'm the primary nurse, you're coming in to help me. I say, Lauren, I have a possible preeclamptic patient here in triage. Can you help get me some stuff?
Yes.
So what are you going to grab for us?
So she's already has her blood pressure cuff on because we have the vital signs. And we've already listened to her lung sounds because of that assessment that's listed.
Excellent.
I'm going to throw in an IV for you and get that going. Maybe draw off some labs to help out.
Great.
And then sometimes the doctors will also order just to start them on fluids just in case. So we might start on LR.
I would agree, but because we're worried about preeclampsia, we don't want to do fluid overload. So what's our number going to be?
So 125 for the total input.
Absolutely. Yeah, we're not going to run a bolus.
And then just in case in the meantime, I will get all sorts of kind of fun gadgets, doodads, whatever, if we need to do anything rapidly. We have that available for
Our
us.
medications?
Medications, so like calcium gluconate, which I know this is in here. Yep, calcium gluconate, but I know it's more so when we start magnesium, but that might be later when the doctor orders it. Might be setting up for an EKG lead as well. Also,
Because of the MAG, right?
because of the MAG. So
all
this
these
is,
things stem from our first intervention of MAG, once we have the order for it.
once we have the order for it, yes. We're going to pad the side rails just to make sure to prevent any sort of harm if she does have a seizure.
Right.
Labs have already been drawn because I did that IV. Let me see here. We do have a cart or crash cart just in case, you know, we have to do a stat anything. We have the crash cart nearby.
And she would be more at risk because of the possibility of advancing to eclamptic seizure.
Yes. And then, these are blank. These are blank. Okay.
Just in case you want to add anything.
Okay. And then I might just have that O2 ready and open just in case she started desatting.
Correct.
But she's got a 100% oxygen, so we might not need this just yet, but just to keep this in the back of mind.
Excellent. And then one more thing that we're thinking, prophylactic for possible seizures coming through. Look in the bag and see if you see any emergency equipment we want to make sure to have in the room.
Suction definitely.
Yes.
In case they have a seizure.
Very nice. All right. Thank you. I appreciate your help, Nurse Lauren. That's exactly what I needed. So you already stated a few of these things. Let's say that our doctor did diagnose preeclampsia and ordered MAG. So you've already got a lot of your things ready for us to get started here. Our hourly assessments we're going to go through per our protocol. Do you know how many hours we run our 3-lead EKG for a patient who's on magnesium?
4 hours.
Excellent. Yep, right in our protocol. And then we're going to do our PIH labs, waiting for them to come back. Why is uterine atony up here? Something that we need to be thinking about.
Because magnesium is a muscle relaxer.
Right, exactly. And so she's not getting the magnesium to decrease her blood pressure. That's not the indication here. It's to prevent risk of seizure, but that side effect, we need to be aware that it might be a harder induction for her, and then also postpartum. We have a higher risk for postpartum hemorrhage.
Yes.
All right, so because this magnesium, we're doing all this extra assessment. I love that you already pulled out calcium gluconate to go right in hand with magnesium. Excellent job. Do you know what our goal serum level is for magnesium?
5 to 7?
Yep, 4.8 to 7.8, so close enough, 5 to 7. And we are not often going to run serum magnesium levels. So this is explaining that really looking at the magnesium level in the blood is not an accurate indicator. She could be mag-toxic with a low serum level because of the way that it accumulates in the muscle. So instead, ACOG recommends that we work on our assessment. So these pieces up here are how we are going to focus to see if she's mag-toxic or not. And that's why our assessments are so important. Now, eclampsia, we've discussed the development of seizures is a possibility. What are we going to be primarily aware of for her?
Airway.
Yes, absolutely. So in our nursing management of a patient facing eclampsia, we're going to think about these things. Have you seen this before?
Yes.
Okay. Is there anything on here you have any questions about?
No.
Okay. So we're going to use this acronym to help guide our nursing management of eclampsia if it comes up.
Okay.
Okay. Any questions?
No.
Okay. Thank you so much, Lauren.
Wonderful. Thank you.